for joining. This is a little bit of an experimental works in progress. For those of you who have never joined us, my name is Sarah Glick. I am a co-director of our UW-Fred CFAR Substance Use Scientific Working Group, and I work very closely with my colleague Judith Suey, who is here as well. And we meet every 2 months as a group to talk about data issues, ongoing research projects, talk about grant submissions, just get a better idea of where things are with people's research. And at our last WIP, we had a discussion and somebody suggested, it might have been Julia, suggested that we have a meeting where we share and talk about different data sets that PIs and other investigators at the University of Washington have that include data related to substance use and could potentially be used by other faculty, trainees, students, fellows for research projects. And so we have a nice group of presenters today. We are going to do kind of a speed dating. I don't know if that's the right term, but that's what we're calling it. Kind of a speed dating thing where we're just going to give every project a couple minutes. I think the projects have 1 to 2 slides each to talk very high level about what they are, what their data includes, and what potential opportunities there are, and then a contact name. So I know we have a lot of students, trainees, fellows on this call, and hopefully some people will be able to access it by recording, and maybe we'll make some connections and get some new projects off the ground. So I think what we will do, though, is a quick introduction, just so we know who everyone is. And then I would like to start with Julia, have you go first. And then Chris, you and your team can, I know you're kind of going to divvy it up. They have a couple of projects they want to talk about. I have a couple of projects I'm going to talk about. And then I don't know, Judith, if you were planning to talk about anything specifically. And then if anyone else wants to give a shout out to a project that they have that, you know, they did put together slides for, that would be fine as well. So I've introduced myself. Judith, do you want to do any other additional introduction of yourself?
No, so I think many of you know me. I'm Judith Suey. I'm a addiction medicine trained physician scientist. I'm in the Division of General Internal Medicine in the Department of Medicine, and I do clinical research, health services research related to substance use and comorbidities like hepatitis C and HIV. So I can, Sarah, give a little bit of overview of some studies, although I'm not quite sure how sort of useful or available they will be for projects, but I'm happy to do that at the end if there's time.
Great.
But I know we have a really great lineup, and so I hope that we have some good discussion and questions at the end.
Perfect. Thank you. Well, we'll just quickly go. I'll just point people out based on where you are on my screen. Chris, do you want to start?
Chris Delaney. I'm in general internal medicine. I'm a research associate professor, and I work on a number of different cohort studies and consortiums that are potentially sources of student projects. Can I throw it over to Sarah?
Everyone, I'm Sarah, and I work with Chris as well as others on the call. I am the project director for the Rural Opioid Initiative that we will be talking about later today. And I'm an early career investigator, research scientist, and I look forward to talking to you all in a little bit.
Thanks, Sarah. Lydia?
Hi, I'm Lydia Drumright. I'm a research assistant professor at UW. I'm actually in the Department of BNHI, which is over in the School of Nursing, but you will find me over in medicine at Harborview on 9th and Jefferson. So I mostly sit with the GIM folks. And like Chris, I work across both a number of cohort studies and do work on clinical decision support around opioid prescribing. And I'll just go ahead and give it to Geetanjali.
Good morning, everyone. I'm Geetanjali Chander. I am faculty in the Division of General Internal Medicine, and today am really here in the capacity of collaborating closely with Chris, Lydia, Sarah on using multiple different cohorts of people with HIV and substance use disorders. Nice to meet you all. Go ahead, Ellie.
Hi, I'm Ellie Batraju. I'm an internal medicine, addiction medicine physician and researcher. I am just starting in my second year of a K-23. Geetanjali and Judith are my primary mentors for that, and it's focused on opioid use disorder and buprenorphine initiations in the setting of fentanyl and working through that issue. So I'm excited to be here and hear about all of your things. And sorry, I've lost track of who's gone, so maybe Sarah can help me.
I'm keeping track. Julia, why don't you go next?
Hey, good morning. Thanks for having me. My name is Julia Hood. I'm a senior epidemiologist at Public Health Seattle King County and an affiliate faculty in the Department of Epidemiology. And maybe I'll pass it off to Noah.
Everyone, my name is Noah. I'm an epidemiologist with the Drug User Health Team at Washington State Department of Health. Most of my work is supporting the overdose education, naloxone distribution program. Our work supporting the syringe service programs across the state.
Thanks, Noah. Amy?
Hi, Amy Lee. I feel like I'm crashing something that it was on my calendar, and sorry I'm here, and I hope you'll let me stay. This sounds like a really great meeting. So Amy Lee, I'm a research scientist. I am currently at the Department of Psychiatry and Behavioral Sciences.
We absolutely want you to stay, Amy.
Okay, great, thanks. And I will pass it off to, I think, Brittany, have you gone?
I haven't, and I'm also crashing. So thank you. Brittany Blanchard, I use she, they pronouns. I'm a clinical psychologist by training, assistant professor in the Department of Psychiatry. I'm on a KL2 through the ITHS. One of my mentors is Judith, and my work focuses on integrating harm reduction practices and strategies within primary care for opioid and stimulant use disorder. And I will pass it to P.
B. Hi everyone, my name is B. Mokisu. I'm a second year PhD student in implementation science at the Department of Global Health. I am pretty new to the substance use space, but I'm excited to be here. Pass it to, I think everyone has, no, Samuel.
Hi there, I'm Sam Jansen. I'm an incoming PhD student, first year in health services, and a TESA T32 trainee.
And I'm Oshu, likewise an incoming first year in the Health Systems and Population Health Department here at the School of Public Health, and also a T32 trainee.
Great, it's so great to have you two here. I'm so glad you made it. Welcome to the WIP. Looking forward to getting to know you over the next year. And why don't we pass it to Caitlin, who is also on that T32.
Yeah, hi everyone. I'm also on the T32 as a postdoc. I did my PhD in epi, and my general research focus was on medications for opioid use disorder. Nice to meet everyone.
Thanks, Caitlin. Gio?
Yeah, hi everyone. My name is Gio. I'm also a T32 trainee at UCLA, actually. But I work out of the CSD, that what does it stand for? Center for Demography and Ecology here at UW, and I'm interested in buprenorphine and corrections. So Sarah looped me in.
Yeah, thanks for joining, Gio. And Ron, you know you're off screen, but love for you to introduce yourself.
Hi, I'm Ron Craig, and I just work at a fiscal and program specialist, so I do some organizing. So if you have any questions about admin stuff, that would be to me.
Thank you, Ron. I think we have everybody. Did we miss anyone? No. Okay, great. Well, let's get started. Julia, I'm going to let you start. I've made you co-host. Hopefully you can share your screen. Excellent. I can't hear you, Julia. You are muted.
Thank you for that. I was saying a year and a half or so ago, I presented to this group a work in progress of the study before we started data collection. And it was a very helpful meeting to get feedback on our data collection instruments. And I'm very proud to see that to say that we are near the finish line in terms of data collection. So so today I'm presenting just a snapshot of what the study is and then analyses that I would love to do and would welcome collaborations on. I'll also spend a moment at the end talking about other King County data systems. So the study, maybe you've seen advertisements for across town. The campaign is Get High, Get Heard. It's an entirely phone-based study. The inclusion criteria for the cross-sectional study are listed here. So it's the key thing is 16 to 35 years old, and then have used opioids and or stimulants at least 10 years in your lifetime. It's fine. And then we've also done qualitative interviews. In the participants in that were selected among people who have completed the survey. And if the qualitative interviews are recorded, transcribed, and included themes. So the focus areas of the study are in the survey, a lifetime history with 14 different drug classes. We asked about each drug class individually. We asked the age when they started the drug class, when they progressed to regular use, and if they discontinued use, as well as the frequency of use in the last 12 months. We go through 11 criteria separately for OUD and stimulant use disorder. And then we asked a detailed set of questions about both utilization and interest in harm reduction in treatment services. We had a section of questions that delve into stressors and different life events. And those range from we asked a detailed set of questions about housing situations, both currently and in the past. And then experiences with trauma and discrimination and chronic health issues. And then we wrap up the survey with asking both your standard demographic questions, but also more detailed ones, like who was involved in raising relationships, your various occupations you've had over time, and religion. The qualitative interviews delve into detail on the drug use history that was reported in this survey. So it's really asking why the behaviors change over time. And then it also asks detailed questions about how fentanyl consumed and how opioids and stimulants are used in combination. To give you an idea, for each person who completes our survey, we generate this type of information. So it's basically a timeline of initiation and continuation and discontinuation of the 14 drug classes listed here. The slash mark indicates sporadic use, where the X's refer to at least weekly use. And so it's oriented by age. So that I feel like we have countless analyses that we could do with this data set. The analysis I'm planning to pursue is tied to our specific aims are listed in the left, and they're really focused on describing the prevalence and timing of the various milestones. So the milestones of interest are initiation of the drug class, progression to regular use, progression to use disorder, and effective recovery. And to describe common trajectories, assess what's associated with these various milestones, and to describe contextual factors for changes in behaviors. We also are going to write the paper on documenting drug consumption practices that would describe the qualitative interviews. There are other analytic ideas that if I had endless hours in the day, I would love to write myself, but I don't. So I would welcome collaborations on these are topics off the top of my head that are of interest. So discontinuation of injection drug use, the comparison of people who report injection drug use versus non-injection drug use, harm reduction and treatment source uptake and preferences by the subgroup, and relationships between drug use and housing stability. We also have a question about the installation, it's finally given the Surgeon General's report. And then I'm hoping we can use this data set to characterize populations that might not be well represented in other data systems, especially data systems that exclusively look for people who inject drugs. So those, the bullets on the right are the ideas for collaboration. And I don't know if I should stop here to take any questions or Doug Rushfield about other things.
Thank you, Julia. Yeah, I think if people have like one or two quick questions, that would be a good use of time.
Julia, thank you for that. That's a very interesting study. And I'm just wondering, for folks in the room and even for myself, if we were interested in using data from your study, especially to integrate or to look at data across multiple studies, do people just contact you? Do you have a concept proposal form? How does that work?
That would be just as simple as emailing me.
Okay.
Yeah, it'll probably be project specific, but I likely want to be fairly involved. And this is, yeah, I think the first step is to get in touch. I don't the data collection is still ongoing. We're hoping to wrap up at the end of this year. So it would, if we got everything in place to start a collaboration in early 2025, that would be the dream timeline.
Yeah.
Perfect.
Great. If there are no other questions, thank you so much, Julia. You want to talk about this then?
Yeah, so I wear multiple hats as a King County epidemiologist. One hat is managing the study that I just described. The other is that I work with a large team of people on integrated data analyses. And I would say that this is a capability and infrastructure that is growing over time. And there's understandably a lot of interest in leveraging King County administrative data systems to evaluate substance use indicators and outcomes. So the types of administrative data that are available are the King County jail booking, as well as King County and UDA jail health services data, behavioral health services, importantly, Medicaid claims data, EMS monitors. We get some ED data with caveats, some housing data with caveats, and then we both access to the King County medical examiner's office data as well. We can support getting approvals to use the state mortality data. So these are really powerful data systems, but do come with a lot of caveats. We are developing our capacity to link across these data systems, and we have some early partnerships with several different UW teams that leverage these administrative data systems. I would say that we're just learning as we go, like the best way to collaborate and coordinate across both the researchers, but then also the parties responsible for managing the data systems and IRBs and program partners. So I want to just say something briefly about that, because some you probably already know people who are tapping into this data resource.
Great, thank you. Any questions about these King County data? Okay. Great, well, we know how to reach Julia. And I really appreciate you helping to motivate this whole session. Thanks so much. Okay, well, let's turn over to Chris and your team.
Hi. So one prelude I'm going to give to all three of the studies we're going to talk about today is they're all really large consortiums with lots of people playing in them. So you're going to see that the data is available, but you're going to hear the word concept proposal a lot. And in order to prevent overlap and to ensure that we can all play in a big sandbox together, anything you do in these studies needs to be with a concept proposal. And that starts with figuring out what other people have done in this space. And so if you're interested in any one of these three studies, my recommendation is that you get in touch with us and we can help you figure out overlap and where you might have novel room. There's tons of work to do in all of these. I just want to make sure that if you look at this and you see your pet idea, it's possible 6 other people have had the same pet idea and are working in a collaboration, which you may be able to join, but I just want to set expectations appropriately. Let me see if I can share a screen.
Chris, can I just add something else?
Please.
So if you do have a pet idea and somebody else is doing that in their concept proposal for all these cohorts or large consortia, we try to find, if you need to lead something, like you need to be the first author and somebody else is already working on it, we try to find something that fits with your interests. So oftentimes we can work out the overlap. So just so people don't get disheartened.
Oh yeah, no, if I was sounding unwelcoming, I apologize. It's more that they're complicated studies. Judith, you want me to talk about ROI or do you want to?
You put the slide together. Please talk about it. Yeah.
Right. So the first one I want to talk about is called the Rural Opioid Initiative. Now, these studies collect huge amounts of data, both qualitative and quantitative. There were 8 studies over 10 states, and they had 2 phases. The first phase was basically based on respondent-driven sampling to create samples of difficult-to-find people in rural America. The second stage was interventions. 7 of the 8 sites went on to an intervention. 1 site, West Virginia, did not. And this is entirely focused on substance use. All the studies in this consortium are focused on people who use drugs. Unlike the other studies that we'll see today, specifically CNICS, there's very little HIV in the Rural Opioid Initiative. I was actually kind of surprised how little. I thought, as someone who does a lot of HIV and substance use together, this is really where I've worked entirely in a substance use capacity. And so you can see that we've got about 3,000 participants from a whole variety of different states. The coordinating center, of course, is here at the University of Washington, which is how I linked into this. And of course, Heidi Crane and Judith Sui are the PIs of this study, and Sarah, who's on this call, is the project director and the person you should contact if you're interested in working with the Rural Opioid Initiative. Does anybody have any questions about ROI? We have Sarah and Judith here.
I just put in the chat some of the domains that we have associated with ROI that might spark some interest.
I guess the other thing to mention is we're in our last year essentially of funding. So if you want to work with this data, probably, speak up quickly and because you'll get good support now if you wanted to work on something. Otherwise, I think there'll probably still be opportunities through HIV Success, which I guess you'll talk about next, right, Chris?
Yeah, Success is next. I think we're debating a second no-cost extension, to be honest, Judith, so it could be either way. Well, just because there are so many projects in ROI that are still ongoing, we may want to just keep monitoring them.
Okay,
so
that's great news.
It's been a very fertile field for study. And so this is one of the ones that I think is really student friendly at the moment because the data collection on the sites has ended, but they've ended with lots of data, all of which is centrally deposited. So you've got people who've kind of moved on to other research projects. Except for New England, all of the studies are closed, and New England is closing this fall. And so you have lots of collected data and researchers who are now being pulled in other directions. This makes them fabulous student collaborators.
And I can echo that. As I mentioned previously, I'm early on in my career and I do not have a doctorate, and I felt very supported throughout the grant from not only the UW team, but also with the other research cohorts associated with ROI.
And this was Sarah's very first author paper, is one of the ones I use as an example. So she went from staff to writing papers because everybody was like, yeah, you're interested in something, go do it. And I think actually it was Judith who mentored you in that, right? So
Yeah,
it's another
Judith.
good example of Judith. All right. We can take general questions at the end as well. Another consortium I want to make people aware of is HIV Success. This is one where I'm actually one of the PIs. It's a big PI team because we were pulling together a lot of different expertise. This is brand new. So unlike ROI, which is kind of the end of its life cycle, I think we almost have data from all the cohorts, but I think we're still waiting for one at the local coordinating center. We are just starting this one. So this is the opposite cast of ROI, where there's lots of data and interesting questions that were left over. This is the early gold rush days where we have lots of work to do and we're just starting on the adventure. This is a consortium of NIDA cohorts. So NIDA sponsors a set of cohort studies that collect data longitudinally on substance use. And their idea was to knit them together with a central coordinating center to create larger samples. Now, this is a little bit of a weird study in that NIDA is currently recompeting the cohorts. And so these are the current cohorts. They may not be the cohorts that are here in a year. However, we will be maintaining these cohorts indefinitely for data support. We just might have additional cohorts that also start up. And you can see there's a lot of exciting and interesting groups here. Everything is very substance use focused. And some of the stuff is very old in the sense of it goes back a long time. If you look at Alive and the JHHCC, these cohorts go back to the 80s. So you can really start to look at long-term outcomes and long-term time trends in substance use with this sort of data. Unfortunately, the stuff on the Better Coast is a little bit more frequent, but you still have VDUS in 1996. So there's a lot of options here. And again, it's kind of hard to describe these things in one slide because Lydia has a list of like 20 domains for these things. And now that I'm speaking, I realize Lydia was supposed to give these slides, wasn't she?
It's fine, Chris. You are just as good as me. One thing to remind people of a couple of things to remind people of with this cohort or this set of cohorts, I should say, they didn't all collect standardized questionnaires. So ROI has standardized data collection, and the next one you're going to see, CNIX has standardized data collection. So, but there is overlapping data collection, and in the future, we'll be doing standardized data collection for them with the new cohorts. So it's a little bit more complicated, but because we are the coordinating center, part of what we do is provide support, especially to new investigators or early stage investigators in working with this type of data. So a nice opportunity, I think, to learn some new stats and how to combine these types of data. And then I just want people to note the website, because right now we don't have it ready. We're working on it, but you will get an interactive sort of dashboard where you can say, I'm interested in MOU and substance use in the last year, and you can see if which cohorts have those data available, or how many people have people who are reporting opioid use, because some of these cohorts on the West Coast, we see a lot more methamphetamine use, and on the East Coast, we see a lot more opioid use. Not that you don't get it on both coasts, but the end changes a lot. I don't know if I left anything out, Chris or Gitanjali. And I just want to put a plug in for everyone collects alcohol use too on assist. So not just drug use, but substance use altogether. Just seeing Gitanjali here and knowing that alcohol is a big passion of hers.
I think the only thing I would add, and again, I am sorry, I was nervous and so it just kept presenting, is that you may have a single study here that you're interested in, and something else that we can do is introduce you to the PIs of these studies. They tend to be very collaborative. Like, I'm not going to swear that there's no possibility you could find a study that wasn't collaborative if you worked hard enough. I mean, there's like probably 50 people who are senior players in this. Somebody will be cranky, but we are very happy to make introductions and link you up with an individual cohort. We're also very happy to think about ways that you could have two cohorts together. We can also be a portal for single cohort data if the cohort agrees in advance to allow us to do that. So if you are looking at Radar and you say, oh, that's the stuff that I've always wanted to look at really closely, we're very happy to introduce you to Brian and, see if there's room for your ideas in his cohort. We're happy to be a stepping stone as well as being a collaborative study. Any questions? Lydia, can I offer you Scenics in exchange for stealing your success?
I am happy either way, Chris. You did
Go
not
ahead.
steal anything
I'll give you
from me,
Scenics.
but you have to run the slides. Okay, so
Yep.
the last cohort we're going to talk about is the CFAR network of integrated clinical systems. Maybe folks have heard about this. The PI, the overall PI is Michael Sag, but we have 10 sites now in Scenics. So there are local site PIs at UW, that's Mari Kitahara and Heidi Crane. And this is a longitudinal cohort of people with HIV who are in care at the 10 different centers. Most of these centers see a lot of people with HIV. So for example, at UW, if you're familiar with that, these are patients from Madison Clinic. We collect, as part of routine clinical care, patient-reported outcomes. That includes substance use and a whole number of other domains, housing, stigma, mental health, you name it. So we have a lot of data that we collect there, and they also bring over key clinical data. So labs, diagnoses, procedures. We also have adjudication of certain key outcomes that we're interested in, such as myocardial infarctions and strokes. There's a whole list of them that we can give you. And the focus of Scenics really is to share, to actually share these data out and get external users to use the data. Mike is very passionate about that. So we can talk a little bit more about that, but they have a well-developed concept proposal set up, and you could work with Chris or anyone else. Chris's email's down here as the contact, or Heidi or anyone else who works with Scenics to put in a concept proposal. And if you just hop to the next screen, Chris. So this is our, these are our 10 sites. It's very representative of most of the United States. We're missing a bit in the middle. They add scenic sites all the time, so we might get more in another 4 years, I think, Chris, right? We just started this cycle, so I wouldn't be surprised if some more come in the middle of the United States. It's a really, really rich cohort. So Chris, myself, Sarah, Geethanjali, other folks, probably Judith, use this data on a regular basis, and these data have produced, Chris, 200 manuscripts now. Is that where we are?
More than 200.
More than 200 and numerous concept proposals. There are currently, the genetic data is currently on 1,200 people with HIV and growing. Overall, there are 50,000 people with HIV have been included in CNICS, but only about 25,000, so about half of those have PRO data, because early on it was just clinical data. Chris, I think we have another slide that shows some of the data. There you go, substance use data. So remember, these are just people with HIV and care. So we don't have necessarily super high, well, depends on how you see it, if you're comparing it to the general population, but super high proportions of people using particular drugs. But because we're talking about 25,000 people, it tends to be a huge number of people. So lots of nice longitudinal data to work with. Chris put together this nice slide showing the differences in substance use at different parts of the United States, to the Northeast, the South, and the West. Lots and lots of interesting longitudinal questions can be asked with these data, and lots of outcomes associated with substance use. Chris and Geethanjali, did I leave anything out that you both want to add?
I will only add, because it's missing, is the alcohol use data are missing from the tables. The Alcohol Research Consortium in HIV is an NIH-funded study that is actually embedded in CNICS. And so we have added a number of alcohol-related measures to the PRO with the goal of really sort of understanding how do we optimally integrate treatments for unhealthy alcohol use and alcohol use disorder into clinical care. So in addition to using the longitudinal cohort data, we actually have ongoing implementation studies within CNIC sites. So lots of very interesting implementation science questions that can also be answered.
And I guess that reminds me to just say that CNICS is very responsive. So as we discover new things, we add in new questions to understand what's happening. So it's very dynamic in that way in the PRO. And there are a lot of attached studies, is what I might call them. They piggyback off of CNICS. Geethanjali was mentioning their interventions around alcohol, there are interventions around smoking, there are studies to look at sleep apnea, for example. So lots of opportunities there, as well as people build their career around sort of an area of interest in CNICS. Chris, anything else?
Yeah, no, it's a very student-friendly cohort. Mike Sag has a statement of, CNICS tries to get to yes. And I'm part of the research review board, and we really do work to try to support people in their concepts. I humiliatingly left alcohol off of the substance use slide because my brain doesn't work properly. But you should investigate ARCH if you have any interest in alcohol research. The ARCH group is really fun to work with, and they've got a lot going on. And they also include Emily Williams from Health Services here at the University of Washington. So I noticed there were some health services people on the call. So if you're worried they're all EPI people, nope, we connect to both sides, especially through ARCH.
Great. This is so useful. Even I, who work in this field and know about these cohorts, I have learned so much. So I really appreciate your team coming out and making it, teasing through all of the differences between these consortia. Really appreciate it. And I hope others have learned a lot as well. now I guess I can take speaker's prerogative, and I'm going to talk a little bit about some data that me and my team have. I know a lot of you have actually worked on these data, so these will not be surprising. I'm going to talk about 3 different surveys that I am the data steward for. The first, I'm sure many of you are familiar with, is the National HIV Behavioral Surveillance, NHBS. Locally, we call this the PITCH study. This is actually funded at our county health department, where I work also as an epidemiologist with Julia, although I'm a UW employee, not a health department employee. So I'm our site PI. This is a CDC-funded cross-sectional survey of populations at risk for HIV. We recruit about 500 people per year, and we rotate annually between different populations. This year, we are in our people who inject drugs cycle. Next year, we will focus on people at risk for heterosexually acquired HIV. Last year, we were focused on men of sex with men. And then we have now worked on 2 different cycles of trans women, which have run concurrent to the other cycles. So lots of different populations, tons of data. These data go back to the mid-2000s. So we have serial cross-sectional data on these populations. Even though one survey in particular, the PWID survey, focuses, of course, on people who inject drugs, all of the surveys use the same instrument. So they all ask about both injection and non-injection drug use. So we do have substance use data from everybody. We also have HIV testing data on everybody. The topics are very broad. I can't do that justice today, but very high level. We have detailed data on sexual behavior, hepatitis C, HIV, more recently PrEP use, STI. It is a very long survey. We have a lot of data. And so there are many, many different research topics that can be explored. Lots of students have used this. It's still, and faculty and fellows, and it's still available for use. It does require public health involvement, but I can help shepherd through that process. It's really not that bad. And one thing I did want to highlight is that it's easiest to access our local data. However, there is also a mechanism for analyzing the national data. So there are 20 NHBS sites. So there's about 10,000 people interviewed every year. And so I have a former PhD student who used the national data set for one of her dissertation aims. So this is certainly something that's available, and the CDC loves to get this data out. So definitely, if you are interested in looking at any of this on a very large scale, I'm happy to connect you with the CDC team. You can contact me. And then the CDC has recently reorganized their NHBS site. So if you want to learn a little bit more about it, you can go to that website, and I will share these slides after the presentation. Real briefly, I just wanted to show, these are all papers from students and trainees. Caitlin's on this call right now. Vanessa McMahon actually used, she collected similar data across 3 sites. She added some questions to 3 of the surveys. And so she did a cross-site analysis, which was really neat. And then Mike Berry and Addie Paliu have also used these data on recent publications. So lots and lots of students have been using these data. Next is another survey through the health department that I co-lead with my colleague, Joe Tinsley, who manages the syringe services program. This is our biennial, so every other year we do this survey of our SSP participants. Last year we had about 500, sometimes we've had less, but now that we have incentives, we're definitely getting a good sample size. This is part of a statewide survey that is conducted in collaboration with the UW ADAI group. So they actually have data from participants of SSPs across the state. So that is an option for some students. I'm just speaking on behalf of what's available through the health department. We're the largest site. All surveys ask about both injection and non-injection drug use, and all of our participants utilize our SSP. So the vast majority of them use drugs themselves. We do have some people who get supplies for other people, but the vast majority of people are drug users themselves. Our topics, this is a shorter survey. It's about 50 questions every year. We focus on drug use patterns, harm reduction, utilization, and some health outcomes. Like NHBS, it's certainly open to UW use. It will involve the health department again, but again, I can help you with that. You can reach out to me. I put the URL for our most recent report from our survey that we conducted in December. So if you're interested in kind of the high level descriptive picture of what our data look like, you can look at it there. And just wanted to highlight a couple of papers that have come from these data. I know Noah's on this call and used these data for his thesis, used the statewide data actually. So just wanted to highlight that, and have worked with some other MPH students on various topics related to SSP utilization. And then finally, I wanted to talk a little bit about Project Nexus. This survey has ended. This was a multi-site CDC supported survey of people who use drugs. We recruited them through 9 US SSPs. So we have a total sample size of about 2,500. Noah was our data manager for the first part of that, so he knows this better than I do. All of our surveys, again, focused on people who are seeking services at SSPs, asked about injection and non-injection drug use. Similar data as the NHBS survey, but again, the difference here is that people were all recruited through SSPs, and we included suburban and rural sites, whereas with NHBS, I forgot to highlight, that is all in urban sites. These data are available for use for UW folks. Kind of like Chris was highlighting, we do have to go through a concept proposal phase, but it's not too onerous. Caitlin has kind of blazed the trail, I guess, with that. So maybe she thinks it was onerous, but I don't think it was too bad. So that is definitely available, and we want to use these data. So let me know if this is of interest to you. I also have a link to the Project Nexus surveillance report that was published by CDC here. And I just wanted to highlight on my last slide, Caitlin was, again, our trailblazer, and she presented a poster at CPDD looking at, we tested people's dry blood spots for different substances. And so she presented that data at CPDD, and that paper is now submitted. And here's just a map of our sites for Nexus in case you're curious. So I know that was truly speed dating for data. Does anyone have any questions about any of these 3 data sets? I'm happy to briefly answer them. Okay. Excellent. Well, reach out if you have any interest in these data. Let me stop sharing. And then finally, I think Judith is going to chat a little bit about some of her data.
Yeah, thank you. I just finished putting my slides together as everyone was speaking.
I wasn't going to tell anybody that.
So, but I want to sort of start out with a caveat that I feel like there's kind of a sweet spot for secondary analyses and supporting trainees. And the studies that I'm going to present are sort of maybe not quite in this sweet spot. I feel like it's, you know, Goldilocks and the 3 bears. And some of these studies are a little too early or on the early side, and some are a little bit on the late side. But I think it's still there are opportunities to be had, and especially for ones that are early, it might be good to have conversations. So I'll go ahead and share screen. So The first study that I can quickly tell you about is called MyApp. It stands for mHealth Incentivize Adherence plus Patient Navigation. So this is a NIDA funded study that I lead, and there are a number of co-investigators who are on this call as well. And it is an R34, so a 3-year study that's funded to do a few different studies. One is a pilot RCT of an intervention that consists of patient navigation plus financial incentives for adherence. And that is going to recruit 40 individuals, and we're about 3/4 of the way there. There's also a qualitative study that's being led by Nick Iacobelli that is also currently ongoing. And then we also have a retrospective observational study built in that's using data from Washington State and also from a registry of patients. So the sample for all these studies are people who are hospitalized and started on buprenorphine, so they have an opioid use disorder, who also use methamphetamine. So the purpose is to try and create interventions for this population of people who use both opioid and methamphetamine use, since we know outcomes are generally worse. So it is a very particular sample. And I think once the data have been completed and cleaned, et cetera, there will be opportunities for secondary analyses, although of course the pilot RCT is a very small sample. So that will limit the types of questions that can be asked. So then the second study is called FOMO2. So that stands for Feasibility of Methadone Remotely Observed Therapy. And it's 2 because it's phase 2 of this study that was previously funded. And I can show we have a number of papers that have already been published from phase 1 that you can look up. So the research is funded to develop a smartphone app that allows for video observed therapy of methadone. So basically remote confirmation of taking methadone, since the standard of care historically has been in person directly observed therapy. So we're now in phase 2, and phase 2 is really an implementation study. So we're doing a step wedge randomized trial to evaluate the impact of introducing this asynchronous video DOT on verification of methadone dosing to see if it can increase the number of take homes that people can get, and also if it can reduce the travel burden for patients. So one thing to know is that really here it's the sites that are kind of the sample. We're facilitating the sites to implement this intervention. But there may be some opportunities for secondary analyses at the end as we plan to get data from the sites on patients and and outcomes like I mentioned, travel, take homes, things like that. So again, open to sort of conversations about these data. So the last study that I'll mention is a study that's now old. So it was completed in 2020. It was a PCORI funded study called the HERO study. It was started in 2015. So this was a study that was an effectiveness study that was followed by a very long longitudinal observational study. So it enrolled people who inject drugs. They had to have injected within the past 90 days and followed them with quarterly visits. And people were enrolled from community health centers and also from opioid treatment programs. So the effectiveness part of the study was comparing 2 interventions. One was patient navigation with directly observed therapy model. So that was really just sort of the first 3 to 6 months. But then there's about 2 additional years of follow-up data. And again, these are quarterly visits with surveys and blood draws. The thing I want to highlight here is that there was a ton of data that was collected. So, and this was for quite a long time in a, relatively large sample of people who inject drugs. There aren't actually that many longitudinal cohort studies right now in the US of people who inject drugs. A lot of the studies like NHBS that Sarah just presented are cross-sectional studies, right? So they ask surveys once a year. So it's kind of a unique opportunity that there's longitudinal data collected on a fairly large sample with such regularity. And I will say, do a little bit of bragging that our follow-up rates were quite good for this type of sample, which, as you can imagine, can be difficult to follow. So these are the type of data that are collected. There's information on stigma, on sort of peer support, there's lab data, there's data on anxiety, depression, and let's see if there's anything else to highlight here. I mean, the other thing I guess I would highlight is there's a lot of information about substances used and sharing behaviors, and not all surveys often ask about this level of detail. So this is from a presentation that I did and a paper that I wrote that was all about injecting behaviors and sharing behaviors within sort of the time frame of treatment and immediately after. So we didn't even use the longer follow-up data. But the thing I want to sort of point out is sort of the level of detail that we asked about, people, if their behaviors, if they backloaded, if they shared cookers specifically or syringes, et cetera. So I do think that there's a lot of rich opportunities for this study. This is the main paper that was published with the main results. We also have a paper on reinfection that came out recently. But the downside is that the data are a bit old now. So I would say this might be a good option for somebody who has really good statistical programming skills. There is a biostatistician that is still involved and is available for consultation, but really it has to be somebody who's going to drive the analyses to write a paper. So I'll stop share if anybody has any other questions. I know we're right on time, Sarah.
Yeah, worked out well. Well, great. I am going to compile all of the slides and we'll send that out to our attendees so you'll have all of this. I am so grateful for everyone for joining, for presenting, for being part of this. I think this worked really well. And if you have any feedback, please share it with me and Judith. But otherwise, we will see you in a couple of months and definitely reach out. We'd love to see some collaborations grow from this. So thank you, everyone.
Thanks for organizing.
Bye, Lydia. Bye, Gitanjali.